It's time to focus on women's health issues. They make up the largest part of the population, but are often forgotten. Maternal and feminine health issues tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. While our topic tonight talks about female issues, they are subjects from which all of us can learn. First, let's take a look at this week's Prairie Doc quiz question. Uterine fibroids are a common non-cancerous tumor of the uterus made up of tissues that grow within or around the uterus. Pick the symptom which does not occur with fibroids. 1, urinary frequency. 2, low back pain. 3, heavy and painful periods. Or 4, diarrhea. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. But all night we will answer your questions about maternal and feminine health issues or family health issues as they are called in or sent to us via Facebook or email. Call in questions and comments to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are OBGYN doctors Dr. Ellen Hopper with Sanford Health Watertown Clinic and Dr. Larissa Bennis with Avera Medical Group Specialty Care Brookings. Thank you both for joining us.
Not a problem.
And it was great that you, of course, you were on the show before. You were on the show. Were you together?
Yeah, we were.
I think it was the first one.
Yeah.
And you used to be in Brookings, but you migrated to Watertown. It's a wonderful town, I have to say. I love Watertown.
It's a little colder.
It's just a little colder than Brookings, not much.
Right.
It's sort of like I used to say Vermilion was just a hot spot of the state.
Yeah, right.
It's so hot. Well, let's talk a little bit about screening before your questions come in, and I really like to have questions tonight. Please call in your questions. But let's talk about screening. The screening, the OBGYN issues, a lot of it is built around screening. Screening for cervical cancer, screening for uterine cancer, screening for breast cancer, screening for infections. Let's start with you, Ellen.
Okay.
What about screening? What do you recommend?
So cervical cancer screening has changed a lot over the last several years. We used to recommend Pap smears for cervical cancer screening every single year, and that's changed. We know that doing Paps every year is not
as important
as we thought it was. Now, depending on age, we screen people every 3 years versus every 5 years with Pap screening, and it's a great screening tool for detecting cervical cancer. There's a lot that has been done with research with the human papillomavirus, or HPV.
Because that's what causes
most cervical cancers, yes.
So it's a wart virus.
That's one virus. Yep, that's one of the types of viruses. And there are multiple high-risk strains that affect the cervix and can cause cervical cancers. So we have women, actually now we don't start Paps until age 21, so that's something that's changed over the last probably 10 years now or
even
so.
If people are sexually active earlier
Correct.
than 21,
Correct.
you don't start until 21.
Because HPV is so common in women, we know that young women that have healthy immune systems can clear that infection. And so we start Paps at age 21. Between ages 21 and 30, as long as your Paps are always normal, you only need them every 3 years. Over age 30, we do something called co-testing, where we check the cells on the Pap that we've always done and also do the HPV screening. And if both are negative, you can space your Paps out to every 5 years because your risk for cervical cancer is so low if your HPV typing is negative.
So and if you have you reach age 65 and you're no longer sexually active, or I mean, when do you stop doing pap smears, Larissa?
And so the current recommendation for when to stop the pap smear screening is if patients have reached age 65 and they have adequate surveillance in the preceding 10 years before that. If they have not had any significant abnormalities during that time, we can choose to discontinue screening at that point in time. In patients who have not been quite so lucky to have had that normal pap smear screening, the current recommendation is to continue doing surveillance for 20 years after certain levels of abnormality have occurred.
So Ellen just said that HPV virus is just everywhere. I mean, it's so common.
Right.
So we can prevent HPV virus. I mean, I'm repeating myself.
Right.
HPV.
Right. Right.
We can prevent it. How do we prevent it?
Right. So there are over 100 different kinds of HPV viral strains. They kind of divide them out into high risk and low risk types. And like you guys were mentioning before, the high risk types are the ones that are felt to fairly definitively at this point lead to cervical cancer. The low risk types are the things that are generally associated with the presence of genital warts. And so to help combat that, a number of years ago, a vaccination had been introduced to protect, at least at that point in time, against the four most common high-risk and low-risk types of HPV, and that's the Gardasil vaccination. Since then, they have now expanded that vaccination to have coverage against 9 different types of HPV. And so it's not going to be 100% coverage against the other strains.
300 or
right,
2,000 million.
Right. But the reason that they have chosen the ones that they have is to cover against the most common high risk and the most common low risk types.
And how effective is this then for protecting against cervical cancer? I mean a vaccination that would prevent cancer.
Yeah, the goal is to eradicate cervical cancer. I mean, ultimately, because of this vaccine. Initially, the vaccine was only given to girls or women. Now we know, obviously, that men need the vaccine too because it's spread through sexual contact. Correct.
And I would say one of the, most common misconceptions that patients have about the HPV vaccination is the false misconception that it is going to promote promiscuity or something along those lines. And so the vaccination is recommended to start ideally prior to the onset of sexual activity. It's similar to any other vaccination in the sense that you would ideally want patients to receive that vaccination prior to exposure to any of that.
Right.
And so that is why
it won't work if you've been
if you've already been exposed to it, it's not going to be effective. And so that's why we ideally would give it to patients when they are still quite young to hopefully. So it can start at age 9.
9 till 15.
It used to be age 9 to 26, and they have now expanded that to 45.
But the parents that say, "Don't give that to my child," she will become more, or he will become more promiscuous. Is there any data to say that that happens?
No.
So, I mean, if you want to protect your child from cervical cancer, or your son from actually some kinds of penile cancer, you're going to want to have that vaccination. Is it covered by insurance most of the time?
Yep.
And it's not just the genital cancers. There are now a lot of head and neck cancers that are also being linked to that HPV virus as well. And so it's a little bit broader coverage than that.
That's a no-brainer.
Right.
But people are worried about vaccinations in particular. We don't have any autism that comes from this. We have no side effects from this. There's no reason not to do this.
Correct.
Your kids have had it. Well, your kids aren't old enough either way.
But
when my children are old enough, I will make sure.
Okay, so we have 3 boys and a daughter, and they've all had it. That vaccination. So it's important to give us your calls. We really like questions from you. It's important. So let's talk about other kinds of screening. We've talked about cervical cancer screening. And certainly one of the things that you do when you do the pelvic exam is you palpate the ovaries and make sure that there is no masses. I mean, that's in the middle-aged woman that you're going to more likely see that. And then with the with that pelvic exam, usually we did breast exams. Now there's been some criticism of breast exam in the office. What's your take on that?
Well, we discussed earlier, now the recommendation is self-breast awareness. So we used to recommend that women do monthly self-breast exams, and now we know that led to more unnecessary biopsies and things like that. We still want women to know what's normal for them. And if that means they're doing exams monthly, fine. If it's every 3 months, fine. But knowing what's normal for you is important.
And what I'll usually recommend to my patients is if they have not started doing that examination or that self-awareness process, that for those first couple times, it's probably not a bad idea to look at doing that on a monthly basis. Once they have kind of started to get a little bit of that familiarity with the tissue, then you can kind of space that out a little bit and, like I said, just kind of make sure that you're keeping an eye on things. I will usually recommend to my patients to look for anything that seems like it's new, different, changing in shape or size, anything that seems like it's fixed or not mobile, because most women will have some
lumps that are moving.
Right, some kind of different texture in the breast tissue.
And they change with their cycle.
Right,
Yeah, exactly.
And so what I will usually say if you push around on some of those lumps and bumps and they move around fairly easily, that's fairly normal. If you push around on those and they don't want to go anywhere, that's not a good sign. We would like to know about that. Would also say we'd like to know about anything that is changing the color or the texture of the breast, or in patients who are not breastfeeding or not anticipated to be lactating, any problems with any nipple discharge would all be things that you should make your provider aware of.
Any comment about breastfeeding? Ellen?
What part of it?
Well, it's wonderful.
Right.
We recommend it for everyone.
And why is it
Yeah.
so important? And are the people in the South Dakota and in the U.S. breastfeeding enough or long enough, or what would be ideal?
Yeah, the goal that the American Academy of Pediatrics recommends is a year. So breastfeeding for an entire year. We now start food in infants at about 5 months. So breastfeeding for that entire year helps with development, IQ. I mean, they've looked at all sorts of things where breastfeeding is beneficial.
It helps promote immunity. It kind of gives some of that bonding experience. And even outside of just the medical benefits, it's also far less cost than being required to continue that feeding with formula, and it's a
really
good thing overall.
And if you're working, you can pump.
Right.
Yep.
And how hard is that? I mean, I really don't have any experience on it.
Well, it's a job in and of itself.
It is.
Yeah.
It is.
Having a baby is hard. Feeding a baby is hard, but it's worth it.
Right.
So, I mean, ultimately, yes, there are better and better pumps. Every year it seems like there's a new pump on the market that is more efficient, and
kind of been trending towards having smaller models that are more discreet, quieter, more efficient, and so.
So it's possible.
So we're really liking this. This is good stuff. It is such a basic and personal act. It brings mom and baby closer together and provides the best nourishment possible.
Unless you're breastfeeding your baby, you're a bad mom. And that is not true at all. The best thing that we can do for our children is to give them the best nutrition that we can, while respecting mothers' choices about how they can be the best mother that they can be. So we need to think about things that are serious, like postpartum depression, postpartum anxiety, postpartum exhaustion. These are real conditions that sometimes preclude a woman from being able to breastfeed. There are a lot of misconceptions about breastfeeding, and one of the big ones is that it hurts. But if it hurts, something's wrong. And so it's important to get support for that, to reach out to a lactation consultant. We actually have the Baby Cafe here in Brookings at Brookings Health System, and that's staffed with certified lactation consultants who can help you with everything from getting the latch correct to making sure that your baby is receiving enough breast milk at a given time. They can weigh them, they can just provide general emotional support. Number one, it has health benefits for both the baby and the mother. Number two, it's something that I think affects everyone in our community and communities worldwide because it is the first nutrition that a baby will receive, and it's something that women's bodies are biologically designed to typically be able to do, and so it's something that is really important to support. Currently, every state protects women for breastfeeding in public places where they are otherwise allowed to be. So this protects them from, for example, getting charged with indecency or something like that. So that's a first step. Not everyone's aware of that, and so sometimes there will still be situations where an employee at a business, for example, a restaurant, will say, you need to cover up, you need to go somewhere else. That's absolutely not true. Women have the right to breastfeed anywhere that they are legally otherwise able to be. Brookings supports breastfeeding developed out of a partnership between the Brookings Health System, South Dakota State University researchers, local lactation consultants, and the Brookings Area Chamber of Commerce. So we came together as a, sort of a coalition, applied for a grant from the Bush Foundation, which is the charitable arm of 3M, and we received funding to hold a public deliberation about how we could improve breastfeeding support in our community in Brookings. So out of that deliberation, the South Dakota Department of Health contacted us. Brookings served as the pilot community for the Breastfeeding Friendly Businesses Initiative. Now, almost 600 businesses across South Dakota in 89 cities are breastfeeding friendly. I think we've come over the hurdle of people being willing to talk about it, willing to say the word breast or breastfeeding, and I think we're at a place where people are tolerating it, which is great. That's better than intolerance. But I think that we can move to a next step to really be supportive and embracing of all the different ways that women are choosing to feed their infants, and to be thinking about how to best support women across a diverse group of employers and life conditions and geographic areas across the state. We, I think, are at a moment where we can move from tolerance to support and to really embracing women's breastfeeding decisions.
Thank you for that comment about breastfeeding, and we sure did that perfect timing, didn't we? Yeah. Remember that this is your program, and your questions are key to the direction of our discussion. Please call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. So we do have a question from Rapid City. What is your opinion on the treatment of prolapsed bladder in an 80-year-old woman? Prolapsed bladder.
So
what is a prolapsed bladder?
Prolapsed bladder I like to explain as kind of like a hernia. Essentially, the tissue falls through the vagina, and there are different grades on exam that
so when they push down, it pushes out.
If you bear down, it pushes out. Sometimes without bearing down, it just sags.
Falls out.
Like a hernia. And there are different treatment options. One thing, you can do nothing. It really depends on how much it bothers you. As long as it's not cutting off the tubes that connect the kidneys to the bladder,
right,
or the tube that drains the bladder, you don't have to do anything. There are other things like pessaries, which are silicone devices that we place vaginally that push the hernia back up. That women can use, and there are surgical options for treating prolapsed bladder.
Right. Do you prefer surgery? I mean, what is your preference? I mean, it seems like if the pessary works, that would be the first thing to do.
Well, I would say it's completely up to the patient. Like Dr. Hopper was saying, a lot of the decision making that goes into these types of scenarios are very involved with the patient. It just completely depends on,
are they a good surgical candidate? Right. Maybe not. Right. Maybe they have heart disease, and then of course the pessary is the better option. Right. Okay. But if it's someone who's young and active and doesn't want to have to deal with putting the pessary in and out, then surgery is a great option too.
And then does the surgery always last? Not
also
always.
Depends.
Never say never, never say always, right?
Right?
Yeah. There's about a 30% chance of recurrence after a prolapse surgery that you will need another surgery or have recurrence.
Okay. We have a woman from Lantry who says, some say that mammograms aren't healthy to get, that self-breast exams can be just as effective. Could you comment on that?
So I would say the preference that I have, or the recommendation that I would normally give to patients, is that while breast self-awareness is good, being able to do some of that imaging has the potential to catch things at a stage prior to what we would be able to feel when we're actually touching the tissue or when we're palpating the breast tissue.
They say 5 years earlier. I mean, it's,
Right.
it's something like 5 years earlier
These
you can
tiny
catch it.
little calcifications that they can see, and then it may be a lumpectomy instead of a mastectomy.
Right.
So it's a good idea.
Right.
Now, we talked about screening, but let's talk about breast mammogram screening. When should that begin? I know that there are people who say it should be 50. The OBGYN, the GYN,
Right.
ACOG, American College of OBGYN, says 40. But there's some controversy about that because women's breasts are denser at 40 than they are at 50, and you can have a lot more false abnormalities, and then they end up biopsied, and so you end up with more biopsies and not cancers. But then you catch a cancer here and there too.
Right. So I usually recommend starting at age 40. Between ages 40 and 50, you could go every other year. I usually tell people if your insurance covers it every year, do it every year. I'd rather catch it earlier and have a lumpectomy than have the alternative.
Right. The radiation, a risk?
Is minimal.
Low. Yeah. Nothing to worry about.
Yep. And I would agree with Dr. Hopper.
After
That's
age
the same
50,
recommendation that we have.
definitely every year.
Every year.
There are, as you were mentioning, there's a number of different organizations that put out recommendations, and so that is where some of that variance comes from. But I think all of the organizations would say after 50 it should be done on a yearly basis.
And then if you have a first-degree relative who has had a breast cancer earlier, usually we say 10 years before that first-degree relative. So first-degree relative would be mother, sister.
Sibling.
Yes.
Right.
Or brother, correct, yeah.
'Cause
Men
guys
can get breast cancer too.
Correct.
Right.
Yeah.
1 out of 100 breast cancers are in a man.
Yep.
Right.
We have a Facebook question. I'm a 68-year-old woman, 2 times breast cancer patient, estrogen positive. I've had painful sex with my hubby and no longer can. Is there help for me? I cannot use Premarin cream anymore. My OBGYN was no help. I mean, so they can't use Premarin because it puts you at a higher risk of breast cancer. She's had 2 breast cancers, and now she is having dyspareunia,
Right. And
which is painful sex.
Right. The Premarin would be a hormone-based cream, and because of the prior hormone-positive status of the breast cancer, and that is likely why that is recommending to be avoided at this point in time. There are a couple newer medications that have come out on the market here relatively recently that are a non-hormonal option for patients who are having vaginal dryness, dyspareunia, those types of things. And so I would recommend that they would discuss some of those with their provider because they would be a very valid option.
It's a SERM, we call it, a selective estrogen receptor modulator. So it does not affect the estrogen receptors in the breast, but does affect the estrogen receptors vaginally.
Right. And you can also just get non-hormonal lubrication creams.
Lubrication.
Go to the internet and say
yes.
vaginal lubrication.
Right. Water-based lubricants.
KY jelly.
Yeah. Refresh, slippery stuff. There's all sorts of different
Slippery stuff?
slippery stuff.
Uberlube,
Yep.
all kinds of things.
That sounds
Uberlube,
interesting.
yeah.
I'm not going there. I'm sorry. Another Rapid City woman asks, is it possible for a woman in menopause to still have symptoms of endometriosis? So what is endometriosis?
So endometriosis is a condition in which, I guess the way I will usually describe it to patients, the most common thought process for why this occurs is that with each period there is going to be a buildup of the endometrial lining, and then when there is not a pregnancy, that is normally passed out through the cervix, out of the vagina, and out of the body. In some patients, what we think occurs is that some of that endometrial tissue can migrate backwards through the fallopian tubes and can
Out
actually
into the abdominal cavity.
and can actually implant into the abdomen. And so endometriosis is going to be where that tissue implant that is still hormonally active will kind of flare up with each cycle. And so you can have a number of issues with that. You can have pain, you can have scarring, it can have implications for patients who are desiring to have a pregnancy in the form of infertility. It can cause dyspareunia, or the painful intercourse that you were talking about. It can cause painful periods in general. And so there's a number of different issues that
There's
can
that
go along with
that old joke, dyspareunia, which means painful sex.
Right.
So they say, you know, dyspareunia is better than no pareunia at all. That's a bad joke, isn't it?
I don't know if some
it?
patients would agree with that.
For
Men,
men.
forgive me. Honey, I'm sorry. Please forgive me.
But in postmenopausal women, your estrogen levels are low, so endometriosis in and of itself should not be causing, you shouldn't be cycling and getting these little implants that bleed into your pelvis and cause pain.
pelvic.
However, if you have scar tissue from prior endometriosis, yes, perhaps you do have,
Or something else could be going on.
Right.
or if you're
right.
on some hormone therapy,
Right.
estrogen therapy, that could stimulate any little implants.
You
that
know,
would
it used
still
to
there.
be every woman who hit menopause, they were on an estrogen replacement so that they wouldn't have their menopause, or they would still have bleeding, but they didn't have the estrogen drop and all the changes that followed that. And
Hot
then
flashes, night sweats, vaginal dryness, all of that kind of stuff, right?
right. And we have a question about hot flashes and night sweats and all that menopausal symptoms. We're not given estrogen anymore, though, are we?
No, not
We do.
necessarily, yeah.
We do.
Right.
We don't give it to everyone. You
Right.
get it if you need it. Usually we say if you have moderate to severe hot flashes, that's why you would get estrogen. The sleep disturbance, sometimes there are other medicines
Right.
that are non-hormonal that
Right.
work for that.
So there is a time still to give estrogen, but you make sure that they understand there's this,
Right.
this tiny risk. It's a
Right.
tiny risk.
It is a tiny risk.
And kind of what we were discussing with the prolapse discussion, this is another one of those topics where it is entirely dependent on how disruptive this is to the patient, if they're willing to accept that potential risk that goes along with the medication.
Then estrogen might be.
Right, then it might be a decent option.
It
There
pulps
are-
up the vagina and it makes it healthier and it doesn't
Right,
get.
right. And in patients where an estrogen-containing medication is not an option, there are also other medications that can provide probably not as much benefit as the estrogen, but can also have
Some relief.
some improvement and some relief from those symptoms.
Okay. Well, okay, so let's say that I'm a woman who doesn't want to have estrogen and I'm having hot flashes and I'm having menopause. What do you usually do? I mean, what are the common treatments that you provide?
Well, I mean, first of all, there's behavior changes. So avoiding caffeine, avoiding alcohol. We know those can increase hot flashes. Dressing in layers so you can take one off when you get hot. Having a fan by your desk or your bed. Many women get hot flashes at night.
Sometimes even something as simple as drinking a cool beverage or something can kind of help calm some of that down.
So the non-medicinal therapies are
Right,
there.
Right.
Then medicinal therapies, there are SSRIs that were initially developed as
For depression,
Yep,
but
depression
they
and
work
anxiety.
for menopause, and that's
Right.
for a different cause.
And we usually use those at a slightly different dose than what we do for treatment for depressive symptoms.
Right. So those can help with hot flashes. We think they can actually help, I mean, of course, with some sleep
mood.
disturbance, mood, yep. And even there's been a little bit of thought on vulvovaginal symptoms too. So
There's other medications that some of them are used for blood pressure, and again, in different doses are used for management of menopausal symptoms. There's other medications that
Like
can
what?
help with. Clonidine is one of them. Gabapentin is another medication that is normally thought of to
Anti-seizure drug, but
or to be used for nerve pain types of things, and that can
Neuropathies.
sometimes also help with some of these symptoms as well.
and there's lots of herbal medicines
Right.
out there
Right.
that we don't have, any FDA regulation on. It's not that some of those couldn't potentially help, but what we worry about is we know soy has estrogen-like properties, and so is there an increased risk for breast cancers and things like that with using too much of those products?
those over-the-counter herbal something's in there that has an estrogen-like
Right.
deal. Now, do you really want? It's an
Right.
if it's an estrogen-like deal, it's an estrogen-like deal.
Right.
I need to finish this question though. This one woman said with hot flashes, I like to drink coffee and it gives me hot flashes during the day. Have you heard that?
That's kind of that
Yeah, the caffeine
component that we were talking about.
Caffeine and alcohol
And hot
can-
beverages, right?
Can increase.
So there it is.
Right.
She could try decaf if she just likes the taste of the
Right.
coffee and see if there's any benefit. But
Right.
Yeah. Have her husband make decaf and not tell her.
yeah.
All right.
Decaf iced coffee.
Yeah.
Decaf iced coffee. Vaginitis can affect women of any age, and we can talk about vaginitis as we come back. An imbalance in the body's biome may be the root of many causes. Its outcomes vary from case to case.
Vaginitis is a lot more complicated topic than it used to be. It's basically what amounts to, if you want to call it, irritation, inflammation of the vagina. From the standpoint of age, there is a difference. You can see it all the way from children to menopausal women. It's probably more frequent in the reproductive years. I saw a thing recently that said 1 out of every 3 reproductive age women will run into some vaginitis issues. Symptoms can be quite wide range. Sometimes just flat out irritation, itching, burning, foul smelling discharge, increased discharge. There can even be sometimes bloody discharge. There can be, one of the more common is symptoms that overlap with bladder infections, pain with urination, urgency, frequency of urination. Before I went to medical school, I got a degree in microbiology. And I was trained as a scientist first and then a physician. The significance of that, I think, is that as a scientist you ask why, as opposed to some of the algorithms we're taught in medical school. I mean, algorithms are good because you don't miss things by adhering to them, but it never allows you to ask why. Probably the biggest culprit, bar none, is overuse of antibiotics in our world. And it doesn't make any difference which age group, but it disrupts the normal flora. In particular, one particular bacteria gets killed off very easily. It's probably the most important one in all of our systems, whether male, female, old, young, and it's a bacteria called a lactobacillus. All humans are supposed to have that. But as I tell patients, it's also the wimpiest bacteria. And so you get antibiotics, and it's one of the first organisms to go. I can tell you about a 6-year-old girl that I saw that social services said should be seen because they're sure there must be some sort of abuse going on, because she'd go to school, she'd wet her pants. She always had to go to the bathroom. She was always fidgeting with her underwear and stuff like that. And so I saw this youngster, and there was no evidence of abuse other than the medical profession. Went through her chart, and from the time she was born till the time I saw her, there was 6 months of her whole life when she was not on antibiotics. So in a sense, she had nothing normal in her system. The environment of the vagina, her GI tract, everything was totally disrupted. And all she had basically was probably organisms that were becoming resistant to everything.
Now that was my good friend and partner in crime, Dr. Goodvangen, Dr. G. And I know that, I mean, I had millions of patients. I would call him every time because, you know, that's his world. Mm-hmm. And he blames antibiotics for a lot of it, and I think he's right. I mean, we have this microbiome, and mm-hmm. particularly in the vagina, and we mess it up with antibiotics. Mm-hmm. He uses a lot of probiotics, too. He'll take Fogia, right? Is that what it is?
Lactobacillus.
Biogia,
Yep.
which is a over-the-counter probiotic, and one in the mouth and one in the vagina for a period of time. Mm-hmm. Those are viable answers.
To recolonize.
Right.
Mm-hmm.
Right.
And then Premarin estrogen cream in women who are postmenopausal into the vagina. Those are all good standard therapies. Mm-hmm. Any other comments that you would add?
There's Premarin cream, there's Vagifem, or Uvifem, I think is the generic now, which is a pill, an estrogen pill that you can use vaginally too for atrophic vaginitis, so the thinning of the skin after menopause. We sometimes see that with other things too, like Depo-Provera use, where your estrogen levels are really low because the Depo-Provera is suppressing those estrogen levels, or in women who are breastfeeding. Sometimes they have kind of an atrophic vaginitis, that thinning of the skin because their estrogen levels are also low. So.
Oh, that's right. I mean, I remember something vaguely about estrogens. That's why they usually don't get pregnant when they're breastfeeding.
Right.
But it's not a perfect method of birth control.
Right.
So, and we have a question that came in, and we should move on to that. What about physical therapy as a conservative option for treatment of prolapse of the bladder into the vagina and pelvic pain and other health issues? What do you think about physical therapy?
And I would say physical therapy is a great option for some of those types of things. It's a non-surgical, non-medication related option for patients that are willing to do that. There can be a number of different focuses, kind of depending on exactly what the problem is. Sometimes patients can have pelvic pain if they have muscles that are too tight. It would be similar to, if you've gone running and your hamstring muscle is just a little bit too tight and it's painful. And so sometimes they can help with relaxation techniques for that. And then you can also have the complete opposite end of the spectrum, where some patients need to be able to improve the tone in some of those pelvic floor muscles, because there are a number of different muscles that may actually make up the base of that pelvic floor. And so they can help patients focus on what that problem is, what the likely cause of it is, and then try to figure out the best method to help them improve that.
Yeah, we love our pelvic PTs,
Right?
our pelvic physical therapists. They're hugely helpful to women.
But
In fact, the woman who wrote in about being menopausal with breast cancer would also be a candidate for pelvic PT. Maybe just dilation of the vaginal tissue there, because she can't use estrogen. Using lubrication and dilators might help her have successful intercourse, pain-free.
So we're talking about the pelvic floor muscles that control the bladder and the rectum and the vagina is within.
Right, the general support
in
of the
between.
vagina, right?
But so urinary incontinence is a problem that I ran into trying to help people with during my practice, and I taught pelvic floor muscles exercises. I mean, you may not have to have a physical therapist to teach you, but some say if you just can tighten the pelvic, all that stuff that you close off when you stop your urine and stop your rectum then you can tighten that 200 times a day is the way to do it. What have you heard this, and what is it called?
Kegel exercises.
And do you recommend
Yeah,
Kegel?
we definitely do. Yep, and I always recommend it postpartum to women, and then usually at annual exams, because definitely can help. I think exercise and strengthening your core can help too. Of course, obesity puts you at increased risk for prolapse and incontinence issues as well. So exercise can help that.
Yeah.
And there are a number of different kinds of incontinence, so just having urinary incontinence does not necessarily mean that pelvic floor strengthening exercises are going to be the correct choice.
Right.
But it can have some fairly significant improvement in an appropriately selected patient.
So we've got a bunch of questions. Thank you very much for questions. Let's just run through it pretty quickly. A Sioux Center woman asks about interstitial cystitis. Is there a time when you can get rid of this? Can this lead to cancer of the bladder? Ellen? Interstitial cystitis is?
So interstitial cystitis is sort of a diagnosis of exclusion, but we typically see when we do cystoscopy, we put a camera into the bladder and look some specific changes in the bladder tissue, so little ulcers, and you have this painful bladder syndrome. Can you get rid of it?
It's a tough question. We could talk all night on
yeah.
this. So quick answer.
I would say no, you can't get rid of it, but it can sort of ebb and flow. So there are some women who are not on medicines and can avoid certain things in their diet and do well for a long time. No issues. There are other women who have to be on medicines forever to sort of help it, or get bladder installations and things like that.
Or removal of the bladder, or a new bladder with intestinal pieces when it's so bad.
I'd say that would be a rare occurrence, but
I've seen it.
Yep.
What causes hair loss during the treatment of cervical cancer, and is it specific to the Native American population? That's interesting.
So I would say anytime patients have a diagnosis of cancer, the treatment is going to be variable, but I would say more commonly hair loss is going to occur from some of the chemotherapy, radiation types of options. And so if that is truly the cause, then no, I would say that would not be specific to a certain population. That would be more of an effective
all
medication.
humans
Right.
were really
Right.
close. And you can grow your hair back after the chemo's done. I can account for that.
Attest to that, yeah.
A Sioux Falls woman said, I had a total hysterectomy at 63. Is there still a need for pap smears?
That would kind of be getting back to the thing that we were discussing there before. If she has no history of prior abnormal paps, if the pathology or the evaluation of the tissue from the removal of the uterus, the cervix, if all of that is benign, and if she's had appropriate surveillance prior to the removal of that uterus and cervix, then no, she would not need to have any additional pap smears. She should still continue to have pelvic exams, though.
Yes.
That is one of the things that I would say is fairly important.
Yes.
When we see patients for well woman exams or for gynecologic exams, we're not just doing the pap smear. A lot of patients get confused with a pelvic exam equals a pap smear. They're two separate things. And so especially in older patients, we're not only evaluating for whether or not we need to be doing a pap smear, but we're looking at the tissues. We're making sure that the tissues appear healthy. We're making sure that there's no concern for enlargement of the ovaries, any of those other types
abdominal
of things.
masses of
Right.
We're doing breast exams. We're
Right.
And we do
updating
Right.
immunizations. We're
Talking
checking
about
lipids,
healthy
all
things.
sorts
Right.
of things.
Encouraging
Yes.
them to exercise.
Yes.
Right.
We like that. One woman asks, as a 75-year-old woman with breast implants since 1965, they're still in, but she's starting to feel a little ridge under her arm. How long are breast implants good? And what kind of care should she seek for them?
Oh, so I am not an expert on breast implants just because it is not generally part of what we perform for procedures. So I guess what my best recommendation would be to discuss with the provider that had placed them or the provider that is currently practicing there.
A plastic surgeon.
Right.
Would do that procedure.
I believe
I think there's all sorts of variation
Right.
in how long implants are good for.
Sometimes
10 years maybe,
yeah,
sometimes
they
forever,
maintain
but,
themselves, and sometimes
Right.
they don't. They get rigid and stiff.
And I think the frequency for when those need to be replaced or reevaluated for replacement is somewhat dependent on the type of implant that was placed and exactly when that was placed, because technology has also changed quite significantly with all of that.
There's a lot of wonderful breast surgery, though, because in some people their breasts are pendulous and long, and there's all these problems, and sometimes breast reduction surgery and breast manipulation surgeries can be very helpful for people. Can you explain genital herpes? How contagious is it, and is there a cure?
There is not a cure. There are medicines that you can take for what we call prophylaxis to try to prevent reoccurrence, but herpes, the herpes virus, is sort of like the chickenpox virus, and once you've had it, it lives dormantly in your nerve cells and you can get reinfected. Some women may have one outbreak and not have another outbreak for years. Some people have multiple outbreaks in a year, and that's sort of how we determine who should we put on suppression with the medicines to kind of keep it at bay.
It's a cold sore kind of.
It's a cold sore, yep. Is it contagious? Yes, absolutely. I think was the other question.
And is it, if you were pregnant, does that require a C-section is done for the delivery of the baby anymore?
That depends on what's going on at time of labor.
Okay.
We will usually recommend that patients be on a prophylactic therapy after 36 weeks, and then if they do have any active lesions at the time of labor, that would be a contraindication to a vaginal delivery.
One man is wondering, how can a husband help his wife stay healthy in this specific area?
I would say make sure that she is seeing her provider on a regular basis. That's, I guess, be supportive, make sure that they're getting the appropriate screening, and what we were discussing with the other general health recommendations. Make sure that there's appropriate diet, appropriate exercise.
Sexual activity.
There may be a little something to use it or lose it.
Yes.
Right.
I mean, really.
Sexual activity is,
Right.
You use it, then
Right.
probably.
Yeah.
We encourage it, doesn't it?
Right.
That brings relationship higher. So
Right.
you encourage that to stop at any age?
No.
No. Okay, a woman says, I am 57 years of age, went through menopause, but never expected any of the symptoms. Why? Never experienced any of the symptoms.
So
Didn't have menopause.
That again is kind of getting back to the discussion that we were having before. Every patient is going to experience menopausal symptoms to a different degree. For some patients, it's a very, very gradual, very minimal transition, and they really don't notice a huge change.
Okay.
For some patients, it's very sudden and can be very disruptive.
A Sioux Falls woman says, my mother is 92 and gets several urinary tract infections through the year. Oh, we're going to be talking about vaginitis. I can feel it in my bones. But doesn't feel any pain and doesn't know she has them. How is it possible she is so unaware of having them? And do they need to be treated?
So yes, they do need to be treated.
Yes, and so vaginitis symptoms can mimic bladder symptoms.
And antibiotics for a bladder symptom when it's vaginitis is only going to make things worse.
Right. So making sure she has that urine culture that truly says, yes, this was a bladder infection, not a vaginal infection. And women after menopause are at increased risk for bladder infections because that elasticity and kind of the beefiness of the tissue is just not there.
On the other hand, a lot of abnormal urine without urinary symptoms, most urinary nursing home patients with quote-unquote bladder infections, I do not treat.
Have them. Yeah.
A Hot Springs woman asked, fibroids are inherited and has them in breast and uterus. What causes these fibroids? I've got one more question. Quick answer. Quick.
So what causes the fibroids is just an overgrowth of a smooth muscle tissue. There can be a genetic component to it, but as you mentioned before, it is a benign condition.
A Sioux Falls woman asks, it's normal to still have hot flashes day and night 20 years after hysterectomy. I'm no longer on hormonal medication and I do not consume caffeine. Do these symptoms last forever? They can,
Again,
can't they?
Very
Right.
variable, highly variable.
Right.
So 20 seconds left. Take-home messages.
Get your regular healthcare screenings, see your providers, discuss any concerns that you have about things, and kind of try to be aware and in tune with your body.
Don't be afraid to bring up anxiety, depression, pain with intercourse.
Incontinence.
Those are always the...
Yeah, they never talk.
Yeah.
And now for the winner of tonight's Prairie Doc quiz question. Uterine fibroids are a common non-cancerous tumor of the uterus made up of tissues that grow within or around the uterus. Pick the symptom which does not occur with fibroids. Urinary frequency, low back pain, yes. Heavy and painful periods, yes. Diarrhea, no. The answer is number 4. Diarrhea does not occur as a result of fibroids, usually. I mean, anything can happen. It was Lana White who answered the question correctly. Thank you, Lana White, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Extra, extra, read the Prairie Doc Perspectives weekly essay in your local newspaper. Over 55 newspapers across the state of South Dakota include essays written by Dr. Rick Holm covering a variety of medical and health-related topics. Ask your local paper if they print Prairie Doc Perspectives.
Women's health can be directly tied to the burden of household responsibilities. In a 2016 study, researchers found that women are more often the primary parent of children, the one who determines family health care decisions, the caregiver for the elderly parents on both sides, and the one that does more of the cooking and dishes, cleaning, laundry, and grocery shopping. Interestingly, doing dishes alone apparently is most burdensome. The U.S. Bureau of Labor says our society is getting somewhat better in sharing the household work, but there still remains a difference. For example, in 2003, men participated in food preparation and cleanup on an average of 35% of his days. And in 2015, it was 43%. Nice to see an 8% improvement, but the woman's share in 2015 was still 70%. In 2015, women participated in cleaning housework 50% of her days, while it was 22% for men. Lawn and garden work was the only chore accomplished more by men than women, 12% of days versus 8%. How much does this happen because the man is often the primary earner? In another study done at the Indiana University in 2016, they studied household work in families where the women's income was larger than the man's. They found that household burdens seemed not aligned with income, but rather with the traditional roles of masculinity and femininity. They also found that in same-sex couples, gender identity still directs roles. We haven't reached equality of the sexes at work, and we haven't reached equality at home either. This is important because of the possible negative effects it may have on family relationships. There are studies to show that each person in a household has expectations and responsibilities, whether it be the alpha mom, the alpha dad, the children, or even the grandparents. If the woman or the man expects the other to pitch in, but ends up stuck with all the chores, she or he may be disappointed, embittered, angry, and feeling abused. If those hard feelings are not resolved and are covered up, then depression may well be the result. When one member of the family is hurting, everyone feels the pain. Research data from Myrna Wiseman, PhD, a professor of psychiatry, shows that mental illness and depression spreads within a household. Strong emotional sharing occurs there, and when emotional pain of one person in the family is treated and improves, everyone gets better. Simply helping with the dishes might be an enormous step toward making a happier home. Well, a big thank you to our guests, OBGYN doctors, Dr. Ellen Hopper, Sanford Health, Watertown Clinic, and Dr. Larissa Bennis, Avera Medical Group Specialty Care, Brookings, for volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University. One of the greatest things about hosting this program over the years is seeing the knowledge and the experience that our many guests have brought us each week. By the way, there were another 1,100 cases of flu confirmed in South Dakota this week, and 2 more people have died from the flu and complications, bringing us to 15 deaths this season. The Center for Disease Control rates South Dakota as widespread and high as it relates to severity. If you still haven't gotten your flu shot, go get it. If you received your shot early in the season, you may even want to check with your healthcare provider about getting another one. This is a very intense flu season that will continue for quite some time. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Being able to move is important. Moving without excess pain is wonderful. Oh, them bones. Orthopedic issues. Next time on Call with the Prairie Doc.
Hello to all. I am Dr. Tom Luzier, a practicing allergist in Aberdeen, South Dakota. Born in Kansas, I embraced the diversity of South Dakota. This diversity comes with a price: limited healthcare resources and information. The Healing Words Foundation, through Prairie Doc, provides an open, online, interactive, public broadcasting format for reliable health information. As a member of the Healing Words Foundation Board, I am asking you please to join me in support of this work, which is funded entirely by donations from you. Please consider making a personal or corporate gift to Healing Words Foundation, a 501c3. Go to prairiedoc.org and click on the donate button and make a valuable contribution. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
Black Hills Medical Society,
Aberdeen District Medical Society,
3rd District Medical Society,
7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.